in a way that made sense for everybody. You have or you will receive a copy of this slideshow. There's a lot of important information on there, and a lot of it I'm actually just going to be reading to you. But for today's purposes, I will actually take you through the slideshow. Each one of these questions was presented to each one of the MCOs, and so their individual answers are provided right here on the slideshow. You're likely going to have some questions that arise, and maybe even some commentary, but if you could just please make a note of that and save it towards the end, we can have that all addressed with our experts during the question and answer portion of the presentation. And finally, I feel we put together a great list of resources for you. They'll be in the slideshow themselves and via attachments, and I'll reference some of those throughout the presentation. So hopefully all of these things will support you further in your billing activities so that you can be compensated for the hard work that you're doing. Okay, and Rana, if you could just advance to the next slide. The first slide, I should say, of the presentation. Okay, let me just move this over a little bit. All right, thank you. So the first question was, when can organizations or agencies bill the H0033 billing code for induction? Most clinics are doing home inductions now instead of in-clinic inductions. Can they use this? Presbyterians provided the answer to this, such as the induction involves monitoring a patient for symptoms of opioid withdrawal, including their vitals, using a scale, administering buprenorphine, and then continuing to monitor for about 3 hours. H033 can only be billed for in-clinic care and should be medically necessary as home induction has become increasingly the standard. So again, as I'm moving through these, you will likely have some further questions, but please note them for the end. Blue Cross Blue Shield gave us some more specific instructions about the billing, and they did reference the Behavioral Health Policy and Billing Manual, which you'll be provided a copy. I'm sure you all have that anyway. But they did reference section C for billing instructions. Number 1, diagnosing, assessing, prescribing, and the initial induction. This includes A, the practitioners with the DATA 2000 waiver, our physicians, our CNS and CNP, that you use the E&M codes for history and physical, and then the induction, the H0033. And they did respond that yes, for home inductions, if provided via telemedicine, real-time audio and video, and that HSD, Human Services Department, has not included this code as eligible to be provided via phone. Next slide, please. Tricky. I believe there was a slide before that because Western Sky would have had an answer to that. Oh, you know what it is? I can't speak because it's on the bottom. Western Sky just responded. Oh, actually, can you go back to the? Yeah, Western Sky responded that they're able to pay claims billed with that particular code, and that they've already been had the ability to pay for that code. So if you have any further questions about that for them, please just save that towards the end, and you could go to the next slide now. Thank you. Are there additional billing codes? All these different screens in here are tricky. Are there additional billing codes other than visit codes 99213 and 99214 and similar that clinicians can use routinely? Presbyterian responded that for the initial visit, the new patient E&M codes can be used, then established patient E&M code for follow-up visits. But this is no different than treating any other medical condition. Now for Blue Cross Blue Shield, they responded that, and they did reference the behavioral health billing and policy manual. Providers are to use the E&M codes for history and physical. If other services are provided, use those billing codes, and if applicable, use one of the following modifiers as outlined in that manual. To distinguish different services that should be reimbursed separately on the same day, use the following modifiers. There's XE, which is a service that is distinct because it occurred during a separate encounter. XP, a service that is distinct because it was performed by a separate practitioner. And XU, a service that is distinct because it does not overlap usual components of main service. Western Sky did respond that the provider should bill the codes appropriate to the service rendered. And if there's questions about a specific code, just please let them know and they'll research that code. Next slide, please. There's going to be quite a few slides dedicated to this answer, or in this question. What are the appropriate billing codes for in-house urine drug screen? Are MCOs seeing a high rate of denials for these claims? Can any guidance be provided to avoid these denials? Presbyterian's response was that if in-house point-of-care testing is done, it should only be done with CLIA authorization, with some of the example codes below from the New Mexico Medicaid fee schedule. For additional lab codes, they've given you a website to reference. If the test is sent out for a lab to do the test, the clinic cannot bill for this work if the sample was collected in the clinic. Finally, excessive ordering and billing for urine testing could be subjected to waste, fraud, and abuse audits. For example, daily urine testing for stable patients. And you'll notice in this particular table, they gave you some codes and the descriptors for that. And I just won't read through all of those because you will have them in your slideshow. But please do reference and review in case you have a question about it later on. And we can go to the next slide, please. Same question for Blue Cross Blue Shield. Their response was that the appropriate billing codes for in-house urine drug screen are dependent on the methodology used for the test. Providers who use an in-house urine drug screen dipstick or cup should bill the CPT code 80305 or 80306. CPT codes 80305 and 80306 are not currently under the prepayment review implemented by SID in April 2018. Facilities that have and use an immunoassay machine for an in-house urine drug screen should bill the CPT code 80307. The provider should review medical policy criteria and the coding and documentation requirements. Medical policies and the clinical payment and coding policies, otherwise known as CPCP, and they've provided you the website address to access those. And again, they've identified the codes and the descriptors for that. Next slide, please. Same question to Western Sky. If it means that the drug screen is analyzed at a lab owned by the provider, the most effective way to avoid a denied claim is to bill using a valid and appropriate CLIA. The next question was had to do with the codes for nurse billing. What types of systems do other clinics have set up for non-MD, PA, and the NP staff to bill with that have been successful? Thinking about nursing visits for directly observed administration of buprenorphine or performing UDS and quick visits. So Presbyterian's response was that MD, CNP, CNS psychologists can bill the E&M codes to include assessment of patient condition for both initial and established patients. These codes begin with 992XX on the New Mexico Medicaid Behavioral Health Fee Schedule. And again, that website has been referenced for you. The agency may also use the H2010 comprehensive med services where appropriate, and to also they're also saying, please reference the Medicaid behavioral health fee schedule for more information. And if there's anything in the chat boxes, I was just gonna check there. Blue Cross Blue Shield's response to this, they did reference the behavioral health policy and billing manual, which you have been provided or will be. The medication administration after initial induction. For practitioners, the RN, which is 317, or the PA, which is 305, under supervision of the MD or the CMP. Then they've got H2010. And per the behavioral health fee schedule, they have provided that resource as well. They also annotated G0493, which is the skilled services of an RN for the observation and assessment of the patient's condition. And that unit is for 15 minutes with a max of 40. This code may also be used by the originating site of telehealth when Suboxone induction is being provided through telehealth. And Western Sky responded that nurses typically bill the same codes as well as all other providers. And again, if there's a specific question about a code or modifier, please let them know and they'll research. Next slide, please. The other question, another question that the providers had is, what MD conference billing codes can be used when talking with team members and discussing patients for improved care? And are there codes that can be used for phone calls to patients? Presbyterian's response was that the interdisciplinary team conferences can be billed G0175, in parentheses S0220, S0221 if patient is present. I'm expecting everyone to memorize all of these codes and we will have a quiz at the end. For more teaming codes, please refer to the New Mexico Medicaid Behavioral Health Fee Schedule. And you'll see that that's been referenced quite a bit. And during the COVID-19 emergency, certain codes can be used for telephonic services, and those codes are listed at the bottom of that document. For Blue Cross Blue Shield answering this question, they reference the integrated care and interdisciplinary teaming in the behavioral health policy and billing manual and gave you specific pages of 37 through 40 for a description of covered services and billing codes. This section includes the following excerpt. I'll go ahead and read that to you. These 6 elements of teaming may be performed by using a variety of media with the person's knowledge and consent. Example, texting members to update them on an emergent event, using email communications to ask or answer questions, sharing assessments, plans, and reports, conducting conference calls via telephone, using Skype conferences, and conducting face-to-face meetings with the person present when key decisions are made. Only the last element, conducting face-to-face meetings with the person present when key decisions are made, is a billable event. They are referencing the interdisciplinary teaming codes on the behavioral health fee schedule and giving you pages 5 and 6. Western Sky answered this question by saying the codes identified for this purpose in LOD 19 are 99446 through 99449, and they can accommodate all of those codes. Next slide. What codes are being used for telehealth? Presbyterian provided to you that you may use most behavioral health codes when clinically appropriate for telemedicine. You must have an attestation in your contract for telehealth services through the contracting department with PHP, and they've given you a contact person for that and his email. Telemedicine requires a HIPAA/high-tech compliant platform for telemedicine services, and there are exceptions during COVID-19. Telemedicine requires the service to be billed with 02 POS and modifier GT. Blue Cross Blue Shield give quite a bit of detail. Covered services provided through telemedicine should include one of the following modifiers: the GT, which is the modifier used to indicate telehealth services via interactive audio and video; synchronous telecommunication systems; the GQ, which is the modifier used to indicate telehealth services via asynchronous asynchronous telecommunication system, or 95, synchronous telemedicine services rendered via a real-time interactive audio and video telecommunication. This requirement is made to the originating site, and that would be where the member is located. And if the provider is hosting the originating site, example, at the provider's office using the provider's equipment for an interactive telehealth system fee, and then that code is HCPCS code 23014. They're also referencing the general, the Medicaid program rule, the New Mexico Administrative Code 8.310.2.12, specifically pages 12 and 13. And they give a new website for that. But the rule includes the following excerpt. Coverage for services rendered through telemedicine shall be determined in a manner consistent with Medicaid coverage for healthcare services provided through in-person consultation. All services are covered to the same extent the service and the provider are covered when not provided through telemedicine. They also reference the Billing and Health Behavioral Health Policy and Billing Manual for telemedicine, specifically pages 29 through 32. Yes, please save all questions until the end. Okay. See behavioral health policy, again, that was the Billing Manual for Telemedicine, pages 29 through 32, that includes the use of telemedicine while providing MAT. Also, they reference procedure for delivering MAT with telemedicine and the best practice guidelines for MAT via telemedicine, specifically pages 114 through 116. Next slide, please. I have to keep moving the little box around. The codes for being used for telehealth, the response from Western Sky was that a large and expanded menu of codes are being accepted during the present health emergency, as long as they are billed with location code 02. If there's a question about a specific code, please let them know and they will research that code. Next slide. Another question the MAT providers had was, what are ways to improve billing for outpatient clinics that prescribe Suboxone? Presbyterian responded that bill as you would the care of any medical illness seen in your clinic. Blue Cross Blue Shield responded that we are unaware of any billing issues. So they're unable to suggest any improvements, but they're happy to collaborate with the provider community if issues do arise. And Western Sky responded that the most effective way for providers to ensure accurate claims payment is to adhere to standard billing practices and follow all directions specified in the BHSC billing manual. Great. Next question. What is the best way to bill for group visits? How are most group visits structured in terms of clinicians, billing clinicians and their time? Presbyterian responded that to bill for group therapy as one would for behavioral health, group therapy codes include 90853 and 90849, depending on group attendees. Blue Cross Blue Shield responded, they have referenced the behavioral health fee schedule again, and that includes the following codes: H0025HQ, group for OTP, behavioral health prevention education service with target population to affect knowledge, attitude, and/or behavior, group session. Code H0038, which is HQ peer support in a group setting with a unit of 15 minutes. 90849, group therapy, multiple family, and 90853, group therapy. Western Sky responded that providers should bill the codes appropriate to the service rendered. If there's a question about a specific code, please let them know and they'll be happy to research that for you. Next slide. Has anyone explored the concept of interim buprenorphine implementation and billing for this? In the concept, a full induction visit is not done until there is clinician capacity to do so. And in the X number of days between patient expressing the interest and the clinician doing the full Suboxone induction visit, patients receive 1 day of Suboxone at a time and have minimal assessment. Presbyterian's response to this is that this would make the induction process moot and perhaps hazardous, as a patient could be driven into precipitated withdrawal. Blue Cross Blue Shield responded they would need to know more about the concept, and that is not something they have explored in detail, and do worry that the overall effort would be more than if an appropriate induction were done. However, they're willing to learn more about the concept and explore on a case-by-case basis. Whereas Western Sky responded that they believe Suboxone could not be prescribed without an actual assessment by the prescribing clinician. The question says that a minimal assessment, but it also references that the actual induction would not be done until there is a clinician capacity to do so. So it depends on who's performing the minimal assessment, such as a prescriber with buprenorphine endorsement, DEA with the X waiver. The prescriber would still need to follow the federal DEA requirements. Kind of asking, is it meant as just a brief assessment by the prescriber in a one-day supply written with the member returning each day with a latter full assessment clinically? They said they could look at the protocol if one is proposed and see how this works with both federal guidelines and their billing. Next slide. Does time-based coding apply for visits? Presbyterian responded that using E&M codes based on time instead of bullet points is acceptable, but ensure documentation supports the amount of time billed for. Blue Cross Blue Shield responded that each billing code has a specific unit value that should be followed. Western Sky responded that yes, for example, please see the ECHO codes listed in LOD 19, which are associated with time-based coding. The next question is that we frequently use drug screens, and are these covered under commercial insurance? Presbyterian's response was yes. Blue Cross Blue Shield responded that urine drug screen testing is covered under commercial plans, but only if the drug screen meets the medical policy criteria and the coding and documentation requirements. The medical policies and the clinical payment and coding policy, CPCP, can be found on the public website and provided that for your access. They've also provided some codes to you. I won't read them all to you because you will have them in your slideshow. And Western Sky did respond that they don't offer commercial insurance at this time. Another question was, we often need to see patients frequently, WRT clinic visits. How many times in a week or month can we have a patient come in under commercial insurance? Presbyterian's response was that visits must be justifiable as medically necessary or be subject to fraud, waste, and abuse investigations. Blue Cross Blue Shield, they would need to know the specific codes and services that are being referred to. And Western Sky said that they, again, do not currently offer commercial insurance. I believe this is one of the last questions that we had, but it does have a fairly long explanation, but we should have plenty of time for question and answer, which I think is what the map providers are most anxious for. The Medicaid code H003, the $300 per unit oral medication administration and direct observation for Suboxone for induction only. We have not used this code because we have heard conflicting messages of how this code is used. It is not clear to us in the Medicaid billing manual either. When it says induction, what does that look like operationally? So Presbyterian gave a pretty detailed response, and they said that induction is the process of transitioning a patient from abused opioids to buprenorphine. This code is only for an in-office induction where a patient is observed starting buprenorphine. And again, most patients can manage this process at home. They've given a brief overview of what should happen in the office if that code is billed. Advise the patient on how to take the medication. Empty mouth, swallow, sip of water, sit in chair, leaning forward, place tablet or film under tongue, allow it to dissolve slowly. Let the saliva pool forward in mouth until completely dissolved. Then assess for moderate withdrawal, ideally by using a scale such as the CALS for more objective measurement, including taking vitals. Administer the first dose, 4 to 1 milligram buprenorphine. Instruct patient to rest for 30 to 45 minutes if withdrawal symptoms measured by CALS persist after those 45 minutes, but the patient does not feel worse. Administer additional tablet and have the patient wait 45 minutes. If the patient feels worse after the first dose, precipitated withdrawal may be occurring. delay subsequent dosing of buprenorphine, re-question the patient about the last opioid use, long-acting opioid use, and consider rescheduling that induction. Next, reassess after the second dose, continue to dose in the manner until withdrawal symptoms are improved or absent, or until 16 milligrams total is reached. If the patient still does not feel well, additional medications to alleviate symptoms may be needed, and the patient may also be sent home with an additional 8 milligram tablet of Suboxone and instructed to take 4 to 8 milligrams. This is a table that was provided by the MAP providers, and we also gave that to the MCOs to look at. Here are the codes that we're using as a behavioral health agency, and they're asking about any other codes that we could be using. We can move on to the next slide. So Presbyterian's response to that chart was it could be readily replaced by the E&M codes for newer established patients. The codes to be used during COVID-19 emergency only, once emergency is declared over, telephonic visits will not be allowed. And then you'll see there's all the different behavioral health telephonic visits and their authorized codes for Centennial Care. Next slide. Presbyterian continued their answer to this question by saying these services will be paid as if the member received services on site and in person. This will remain an option for providers through the termination of the emergency declaration and applies to both initiation of care as well as treatment of established patients. Initiation of care can be for any reason, including member self-referral. They also stated that providers are directed to bill for behavioral health telephonic services using location code 02. Telephonic visit on the claim form. If location code 02 is on the claim form, the services are billable to PHP and should be paid at the normal rate for the service. All other normal modifiers should be included on the claim if otherwise required. And the originating site HCPC S code Q3014 is not billable for these services since the normal office visit payment is to be made instead. These visits will be considered as equivalent to in-person visits through the termination of the emergency declaration. In accordance with the existing policy, providers are expected to maintain all appropriate medical records. Any medical records requiring in-person presence, example, height and weight, are to be noted in the record as excused per state declaration, re COVID-19. Telephonic behavioral health visits must be synchronous, that is consisting of live voice conversation with the patient, and asynchronous or store and forward visits are not payable under that provision. Telephonic behavioral health visits must take place during normal business hours as if the provider's office were open and the member were able to attend the visit in person. Services must be provided by a practitioner who is contracted with PHP and within the practitioner's normally allowed scope of practice. Blue Cross Blue Shield responded to the Medicaid code H033, same question, was that an induction is a sort of buprenorphine. An assessment for the appropriateness of MAT should be done along with other medication, medical and psychiatric conditions assessed. All appropriate lab work should be obtained or reviewed. The opiate use disorder should be confirmed and risk and benefits of MATs reviewed. The member should give informed consent. The member is to be monitored to make sure the COWS score is an appropriate level before the medication is taken and the member appropriately followed. At home induction is fine and monitoring can be done virtually. In question to that chart, that table we saw earlier, the behavioral codes that were being used by our MAP providers, Blue Cross Blue Shield is also saying, please see the behavioral health fee schedule for additional codes a behavioral health agency may bill. Next slide. Same question for Western Sky. They give a specific rate on the behavioral health fee schedule of $388.50. The description is oral medication administration and direct observation for Suboxone as stated. And again, an answer to that chart of behavioral codes. They're saying that providers should bill the codes appropriate to the service rendered. If there's a question about a specific code, let them know and they'll be happy to research that. There were questions about billing for Sublocade. Presbyterian responded that Presbyterian Centennial Care members, Sublocade must be obtained from a network specialty pharmacy available through Optum Rx specialty pharmacy, and that healthcare providers are able to acquire Sublocade from a network specialty pharmacy that handles and stores specialty medications and dispenses them directly to the office for administration to a specific patient. It is covered without a prior authorization, and they did list the following quantity limits. I'll have you reference your slides for that information. And they're giving you a billing and coding guide for Sublocade and where you can reference that. Blue Cross Blue Shield and Western Sky can answer general questions for billing for Sublocade during our Q&A. Next slide. This slide is actually answered specifically by Behavioral Health Services Division. Question was, would it be possible to create an opt-in IOP and receive some guidance on how one could be created and billed for? So any agency can apply to the IOP through our clinical services manager, Tiffany Nguyen. She wants you to consider these questions before you proceed with the application process. Number one, who do you want to serve? Number two, what evidence-based practice do you want to use? Does this evidence-based practice align with regulation? If yes, please move forward. If no, call Ms. Nguyen to discuss that further. Is your population adjudicated? If yes, that involves another discussion with Ms. Nguyen, and if no, you may move forward. What does opt-in mean to you, since this is a voluntary service? And the billing code is H0015, a bundled rate. So you have to do individual, family of choice, and group. It's billable in 60-minute increments only. Adults have to have 9 hours per week, a minimum, and adolescents have to have 6 hours per week. Your patients must screen in at a level 2 via the ASAM, and if you are a mental health provider, you'll need good justification for that level 2. The application process actually begins with an email to Tiffany Nguyen, and her email address has been provided to you here. Okay, this, bring their specific questions out.
Rana, can I make a general comment? This is Dr. Jankowski. I would just like to point out that I would hope that treating opioid use disorders is like treating a medical illness like diabetes or bipolar disorder. And the billing is similar. It's E&M codes, it's initial psychiatric code. You do an E&M code when you're doing the history and physical, when you're taking a history. If you have a behavioral health provider looking at the individual, you can do the psychiatric assessment code. I think what throws people, and you order labs when you're treating diabetes, you order urine tests, you order labs when you're treating bipolar disorder with lithium, for example. So it's not that much different. I think the induction code is what throws people, because induction is when you, and if you're a provider, you know what induction is, and you know about precipitated withdrawal, and the person has to come to you off whatever opiate they're abusing for at least 12 hours. Otherwise, the Suboxone is going to put them into severe withdrawal, and they're going to be super uncomfortable. If you do that induction in your office, and you're doing a COWS scale, and you're doing, you're seeing the person take the Suboxone, you can bill for the induction code. And I hope the ECHO program is covering this. I've put dozens and dozens of people on Suboxone. I've never done an in-office induction. I always do at-home inductions, because it turns out most of my patients have already experimented with Suboxone, on the street, and sometimes got in trouble and sometimes not. So what I used to do was give instructions to the patient on how to do an in-home induction. Call this number, and 99.9% of the time it worked out fine. So don't let this induction thing throw you all off. I think and I'm happy in another venue, although I'm sure the ECHO program has covered in-home inductions in the past. Rana, I don't know if that's the case, but it's becoming increasingly standard. I think if you have somebody maybe on methadone, you're transitioning from methadone, or maybe they're they're not really following the program really well for whatever reason, because they've got other disorders, you might want to do an in-office induction. But the bottom line here is this isn't neurosurgery, and I would hope y'all could treat opiate use disorders with Suboxone like you would, another medical or psychiatric illness that involves psychopharmacology. Thanks for that opportunity.
Thank you.